Thank you. So we over to Barcelona, where Professor Manuel Bernal-Sprekelsen just about to start his case along with Isam Alobid. So, hello, Manuel.
Can you hear me?
Yes, we can. Good morning to
Good
you,
morning.
Manuel. Good morning, Isam, the team Barcelona, your theater staff, and your IT
Fine, we
technicians.
are okay.
So,
Yeah, we
thank
are
you,
fine.
all of you.
We might
So, welcome, and I'll
present
let you
the
talk about
case
the case,
before
please.
starting.
Yes, please.
Good morning from Barcelona. So I'm going to present the case real quick. It's a 62-year-old male with nasal polyposis, no history of asthma or during colon. It was a grade 3 polyposis. It was given oral steroids before surgery. And here's the CT. So it's partial occupation of the maxillary sinus and a complete occupation of all the edge cells. And here are the statement sinus with no occupation at all. So, well, welcome, and I'll get you with Professor Bernal and Professor Alobid as we start surgery.
Manuel, what's the surgical plan
Good
for
morning,
this
Ashok.
patient? Hi, good morning, Manuel. What is your surgical
Yo no lo
plan?
entiendo, no lo oigo bien. Good morning, Ashok. So
Good morning, Manuel.
I have introduced now a couple of cottonoids soaked in topical anesthesia and vasoconstrictor, and you will see that there are, I'll show you the left-hand side now. This guy went down from a polyposis grade 3 to now 1 or 2. And the problem of his anosmia is, as you can see, that there are a polyp formation in the olfactory cleft back to the superior turbinate. There are minor polyposis in the middle meatus. And as you could see in the CAT scan, the frontal has some occupation, the maxillary has some occupation, and also the sphenoid sinus a little bit. The trick here is that this guy has no asthma, no aspirin intolerance, and therefore we expect this surgery to be not a bad outcome. So the patient underwent already 2 years ago, 3 years ago, a septoplasty with surgery of the turbinates. And as you can see here, the inferior turbinate is pretty stiff, but I have enough space to work in. And el ostrum. And I'm not sure whether me puede enfocar a mí ahora. I'm going to show you my position right now. I'm standing. And also I am using the 45-degree lens. And now if you look at the angle of the 45-degree lens entering the nose, and if you compare to which picture I have inside the nose, you will notice that my endoscope and my instruments will never collide and clash in that area because my angulation here is completely different. Had I be using a 0-degree lens, the entrance would be this one. So parallelly to my instruments, and I would always have a problem, an issue with my endoscopes. And that is the reason why I mainly use the 45-degree. Now, I only have the tip, look at the tip here. I only have the tip of the endoscope inside, and I'm having a perfect overview of the middle meatus and everything else. Okay, so, podemos pasar a imagen endoscópica otra vez. Ready? Okay, now I'll try to identify the uncinate process which needs to be removed. And you see the turbinates are pretty stiff. That can sometimes be an issue. You can also see here that the uncinate process is slightly lateralized. So it's not that much prominent. So the trick here is trying to get inside the middle meatus, which with that instrument at this stage is not possible. So I would warn you against, warn you against infracturing the middle turbinate, because that will make the this was the backbiter. ¿Quién lo pregunta? I was using the backbiter, but I couldn't enter the backbiter. So I would need a pediatric backbiter. So the first issue here when doing a FESS is to identify the uncinate process here. Yes, the uncinate process usually bounces back. You can see that right now. I push on it and it comes back to its original position. Okay, contrary to the ascending process of the maxilla, which is a tough bone. This is the area here where we would look for the lacrimal sac. So again, do not infracture the middle turbinate. Otherwise, this becomes unstable and the middle turbinate then will become floppy. So again, I'm trying now to do the uncinectomy, and usually I prefer the backbiter. The backbiter allows me to keep myself away from the orbit because you bite anteriorly. But in this particular case, you see that the uncinate is a little bit lateralized here, and the bulky instrument does not allow me to go in. So once identified that floppy uncinate, you can now with the sharp side of the frere, you do the incision around here. And the advantage of doing that with a frere in comparison with the sickle knife is that you will see that my dissection area is flat, as you can see now, is flat and full. Had I used a sickle knife and you have huge inflammation in that area, then the disadvantage is that you break down the mucosa and the bone. So I have now a tanto agua, tío. Aspirador curvo. Fino. So now I have created a very nice surface, which I can identify as the uncinate. There is still uncinate remnant here, as you can see. There is uncinate remnant there, which I will then remove with the backbiter. I have created a nice surface here, and now I will use recto cortante.
So Manuel,
use
that's
a true cutting instrument.
Hello, Manuel.
Yes.
Yeah. Okay. So that's great. I mean, you're showing the antegrade uncinectomy. So that's a different technique than what we have seen so far. Hello, Manuel. We are with you now.
Yes. Hello.
Okay. Hi. So if you just take us through what you have achieved so far. Yes, we can.
Okay. I have meanwhile removed the polyps here in the middle meatus and skeletonized the remnant uncinate, as you can see here. That's the uncinate. That's the uncinate, and here's the uncinate. So there is a remnant, small one. So despite using a 45-degree lens, it is almost impossible to identify the natural ostium. So with a 0 or 30, that is not possible. And now I'm approaching the natural ostium here, but I still need to remove that uncinate here. And I'm now going to try to use the backbiter again. I would love to have pediatric backbiter ostrom, but I do not have it here. So, but I have a little bit more space. And now the trick of removing the uncinate is to go behind the uncinate. Look, say the uncinate, and you can almost see by translucency here that I'm behind. And now you can start to smoothly remove the uncinate. Luxate and remove. Luxate and remove. And with that, you're moving away from the orbit, and that keeps you on a safe side. And now you go downwards. You put yourself behind the remnant of the uncinate here. Try to luxate as good as possible, and then remove that uncinate. Importantly here is not to bite too strong anteriorly, because then you would end up in the lacrimal sac, at least here. And now you can check the horizontal aspect here of the uncinate and try to get rid of it as good as possible. And you see, before biting, I put myself behind the uncinate here, and then I bite, because that keeps me on the safe side. And I know that what I'm removing is the uncinate only section. So, back again. This is part of the uncinate I will remove later. Okay, and now I can palpate, if I like, the area where the uncinate was located and identify the horizontal aspect. So the uncinate, as you know, comes from anteriorly and superiorly and goes down in a C-shaped like position, and now posteriorly. So here I have now the horizontal aspect with a fontanelle there. I still need to remove and come anteriorly. And as I mentioned initially, that uncinate on this side was slightly lateralized. So I have difficulties in getting behind the uncinate here and luxating it. I'm trying to do that now with the curved section. And as you see, I broke in the remnant uncinate here. That is the uncinate process going backwards. And you see now the fontanelle here attached. That's the fontanelle, and that's the uncinate. Blakesley recto pequeño. This still needs to be open. And I will see how to do this. Usually I try to clearly identify the natural ostium, which is now probably a little bit easier if I start to remove this. But as you can see, I cannot identify it, and most probably it's going to be somewhere here where my suction is able almost to enter. Now I'm trying to identify that. It is probably here in between that area. So here I can now slightly push laterally and downwards, never upwards. Riga. Okay, and now I can break in that fontanelle in that area, as you can see. And now I know I am in the maxillary sinus, as you can see. Again,
okay, thank you, Manuel. So that was a great demonstration about how to deal with the uncinate.
This is the opening of the maxillary sinus, backbiter.
Okay.
Thank you,
Manuel. So, sorry, I said there's a good demonstration on how to deal with the uncinate remnant and remove the whole uncinate process approaching the maxillary sinus. Hello, hello, Manuel.
Yes.
Manuel, can you hear us?
Riga.
Yeah, we're back to Barcelona.
I can hear
so if you just, thank you. So if you just take us through what you have achieved so far.
Absolutely. So
thank you.
I have a little bit of bleeding here, but I can show you what I've done so far. Esto está obstruida. Sí, porque es el ruido. Okay. I have now enlarged the middle meatus antrostomy. I have now worked on this mucosa to cover that area. Riga, por favor, Riga. And you see, you have a large and beautiful opening. with the maxillary sinus now well aerated. There was a little bit of mucus here. I have skeletonized now the bulla, which is exactly here in front of me. You can see that. That is the bulla. And I have cleaned up the frontal recess before opening the bulla. So I still need a little bit of working up here. And that is now the advantage of using. But I wanted to show you something else, curva, cucharia curva, before I proceed. And that is when what I like to do is whenever I remove the uncinate process and coming here from behind, okay, I remove the uncinate process. And whenever I reach that area here where I'm approaching to the axilla, I try to keep that mucosa here. So I remove the bone of the uncinate coming from behind, but I do not bind the mucosa. And the reason is that once I have removed the bone, as you can see here, that is the mucosa, I have preserved, see that? And once I have removed the bone behind, I just gently push the mucosa laterally in order to resurface the underlying bone here. In that order, we do avoid the head of the middle turbinate getting attached to the lateral wall, and thus we avoid synechiae in that area. It's a little bit more pretty than usual, but that's the way I prefer to do that, and then I can avoid that. You can see that my middle turbinate is still stable, still in its place. I have not luxated it, not infractured it, and I will now put a cottonoid here and show you what I have done on the other side. Again, important whenever you have to, Lentina, whenever you have to introduce a cottonoid into that area where you have been working, there is a higher risk of producing a fracturing of the middle turbinate. So do that always under visual control, as I'm doing right now, and then with a Freya or any other instrument you feel comfortable with, you push that cottonoid inside, taking care of not fracturing the middle turbinate. It's almost like in a stapes surgery. You go around the stapes and try not to luxate it. That's it. Now we go to the other side, where I have already performed the middle meatal anatomy. Okay, and now you will see that. Again, middle turbinate stable. You understand now, if you go backwards, why that patient has anosmia or hyposmia here in these polyps. This is a very nice indication to use the microdebrider I have ready here, but I will do that later. Very important whenever you remove the polyps with the microdebrider here is to keep the biting surface laterally, not medially, and only removing mobile polyps. Do not try to clean up the whole olfactory area. So again, right side, I have created a larger middle meatal antrostomy, as you can see here, with a good aeration. And I can go in, there's a minor polyp up there. I can rotate, I can rotate and can see the infraorbital nerve already up there. And another tip here is, whenever you have to remove the fontanelle, you see that I kept the inferior aspect of the fontanelle. See that here? That's the inferior aspect of the fontanelle. Try to preserve that inferior aspect. And the reason is, you want to enlarge the natural ostium. Remove the superior third of the fontanelle. And the reason is that the vascular supply of the fontanelle is larger in the inferior aspect than in the superior third. So you can go and use a true cutting instrument in that superior aspect here, there, but try to preserve the inferior fontanelle. Then you will have less bleeding. And the reason again is that the vascular supply of the fontanelle is much stronger here at the superior at the inferior fontanelle. Okay, here again I have skeletonized almost the bulla. As you can see here, I can palpate the bulla here, and I will open it later. That patient has undergone an important osteoneogenesis and or at least osteitis, because that bone is really tough. The bone is really tough, so it really took me a lot of time to remove and clean the superior aspect of the frontal recess.
Thank you, Manuel. Yeah. Well, back to you, Manuel. Thank you.
Yes, I hear you. I'm struggling with the anatomy here because the patient has had probably an osteitis. So every single cell and bone is stone hard. So it just took me really almost laying upon the patient to open the bulla on the right side. And meanwhile, I have struggled to open the frontal on the left, as you can see. This is again the mucosa I was trying to preserve, and then later with the packing will achieve. And now I'll show you how it looks like in the frontal here. That's the frontal. That's the opening of the frontal. Wait a minute. Come back to you. And this is the intact bulla technique. This is the anterior wall of the bulla here, which is still preserved. I have skeletonized it, as I mentioned. And now I'm going to go upwards. And this is the opening of the frontal now, which took me a lot of work because the bone here anteriorly, see that small beak there? That beak is stone hard. And I need to use one of my favorite forceps, which is the Hosemann one. Can you, Hosemann, otra vez? And I'm trying to enlarge it just a little bit. Now the question is, how much is enough? And enough is when you have around 4 or 5 millimeters opening. That is usually enough. And how can we measure that? Irriga. Well, that's very easy. You go in with that suction device. The tip of the suction device is 2.5 millimeters. So I have now 2.5 from here and there. So I have almost 5 millimeters. The edema of the mucosa are not counted. And from above or from anteriorly to posteriorly, I will have around 4 millimeters. Okay? Inside the frontal, we had polypoid mucosa, as I was trying to show you here, there, but basically with the topical treatment, the polyps that were here at the entrance have been removed, and I hope that with the topical treatment, this will stay open. Now, cucharilla recta. I will try to show you the bone of all these single lamellas. And I'm now going to open the anterior wall of the bulla, which is here. And now look at how much I have to push. Look at the head of the patient. Wait a minute. Look at the head of the patient. I'm moving the head of the patient fully because I'm almost unable to enter the anterior wall of the bulla. So that's the current situation right now. And you can imagine that that has been so far for every single cell I have opened. This is now the anterior wall of the bulla, curvas, y esta está torcida, esa de aquí. La punta está torcida. Okay, this is now part of the anterior wall of the bulla. And from there on, I will try to identify, that is the superior insertion here of the wall of the bulla, which I will now try to remove superiorly. There, you can see that. Curva, cucharilla de 45, eh? So this is now the posterior wall. That is the basal lamella. You see that the bulla had almost no posterior wall. So this is now the basal lamella. See that? Can be very clearly seen. minor polyposis there or edema of the, but I will first remove the most superior aspect of the bulla in order to have a broad and large frontal recess opening.
Ashok, you're muted.
I'm muted.
Sorry. We just ran a poll about the GNA, the case that Paolo just did. It's regarding the practice of embolization and how many surgeons did embolize before operating on a GNA. So I think there is a 67% of them are embolizing before the surgery.
Yeah, well, that's well, from my point of view, if I may participate in that discussion, strongly depends on the type of DNA. If you have a stage 1 or 2, well, you can think about it. But in the larger ones, certainly. So remnant bones here, which are the so I have.
I think in your case, Manuel. Hello, Manuel.
Yeah.
I've just seen you demonstrating the intact bulla technique to approach the frontal sinus.
Always.
Do you want to talk about it? What are the advantages you see in that?
Well, the advantage of using the intact bulla wall technique is that you stay, first of all, in front of the anterior ethmoidal artery, which is important. The anterior ethmoidal artery is, in almost all cases, in almost all cases, behind the attachment of that anterior wall. So if you keep that anterior wall, you are at no risk of producing any lesion there. Second, while you preserve the anterior wall of the bulla, you also protect skull base. And that's a major reason, of course. And then from an anatomical and physiological point of view, the frontal always drains into an area which is located between the uncinate, which was here, and the anterior wall of the bulla. So even if you open the bulla, that will not contribute to the drainage of the frontal, which is now open here. So I have a large frontal recess now. As you can see, the opening, as we measured before, is between 5 and 4 millimeters in an AP and lateral extension. Now I have removed the superior attachment of the bulla. There is here a small lateral attachment still. And what I can now do is to open the superior third of the basal lamella or ground lamella, cucharilla recta, in order to do so. And that is now one of the advantages. Now, this is still a suprabullar recess, retrobullar recess, sorry. This is a retrobullar recess up there. Okay, now you can see I'm not going to remove the whole mucosa here. That patient, please remember, has no asthma, has no intolerance to aspirin, so no Vidal or Samtal triad. And from that point of view, I do expect the edema of the mucosa to respond to topical treatment now that everything here is open. So, and now, this is now, as we mentioned, the basal lamella here. You know the basal lamella has a vertical aspect and has an horizontal aspect. You can check. Here we go. Okay, very good. So, and now you see the advantage of progressing from anteriorly to posteriorly, because now, in order to have a very good orientation, you can check the posterior wall of the maxillary sinus here and the roof of the maxillary sinus, that is the floor of the orbit. And you already know that following that line, I'm now painting with my suction that line here, that the sphenoid sinus is probably somewhere around here, okay? And that is important to understand when you do that type of surgery, that certain landmarks point at other landmarks. Okay, now let's go here and try to, that is still the retrobular recess, cucharilla recta. Now let's open the vertical aspect of that ground lamella, which is here, and I'm pushing towards that smoothly, always smoothly, and then before withdrawing it, rotate it a little bit. My goodness, this is stone hard bone. It's unbelievable. I cannot always get it out. Hardly. Now that is now the most superior aspect of that vertical aspect of the ground lamella. And with that, I am in the posterior ethmoid, rectal aspirador recto ahora. I will show you that in a minute with a straightforward suction. Presto, te fa coagulare. There we are. See, that is the limit here, and now I'm inside the posterior ethmoid. There we are. Now the question is, how much do I need to open? Because again, you see, there is an edema of the mucosa here, which I can remove, cucharilla recta. But otherwise, there are no polyps in that area. No más fino, me chupa mucho. There are no polyps in the area. It's just an edema. And once I have opened this, I'm it's unbelievably tough. Pinzas rectas. Aspirador recto. Okay, here we are. So this is the remnant of the ground lamella here. This one is a remnant of the ground lamella. I have removed the superior third of it, and now with my suction, I'm inside the posterior ethmoid. Small edema here of the mucosa. Well, you can call it polypoid mucosa if you like. Pinzas rectas, and remove it. At this stage, where I sometimes would like to use the microdebrida, I don't in this particular case. And the reason is that the bone is so tough that I am afraid to break down the microdebrida, and that for these minor polyps here, I don't need it. Okay, that it is. Now we are here at the posterior ethmoid. The mucosa will respond to a treatment, and that's it. And again, the middle turbinate is still stable. It's still in its place, okay? So, cotonoid, una lentina. Bueno, casi. I will put in a cotonoid here and then proceed to check the polyps in the olfactory fossa, cleft. Fossa is intracranially. Again, taking care not to luxate the middle turbinate very smoothly, always taking care of the head of the middle turbinate. We can come back later to this. Okay, and now we can check this. Aspirador. Okay, now this is the tail of the middle turbinate. We can now go upwards, and you see that most of this polypoid edema is coming from the middle turbinate, but most probably also from the superior turbinate. Now the question is, how far do we need to resect this? And first of all, I'd like to check Cucharilla recta. I'd like to check this polyp here because there are two situations here. One is the polyp here is growing coming from the superior turbinate. And the other situation is the polyp is attached to the mucosa of the septum. These are two completely different situations which you have to handle in a separate way. And as you can see here, the mucosa is free. So there is polyp here, but it is not growing from the septal mucosa or the olfactory cleft. That is a very important prognostic factor. You see that now? Can you see that? So the mucosa is free from the septum and the olfactory cleft. That means that the polyps are growing here at the medial wall of the middle turbinate and most certainly from the superior microabridador. And that allows me to generously remove these polyps without running any risk of producing a lesion of the olfactory cleft. In order to do so, as I mentioned before, you have to take care where to put the opening of that. So ideally you go in, you go in, you go in, and then you rotate in a way that the polyps are sucked in, but the mucosa does not undergo any type of lesion. And for this particular situation, I will probably change the endoscope because I'm working now straight downwards, endoscopia de cero. And with a 45-degree lens, I will have minor issues in seeing what I'm doing. I have now trimmed the turbinates a little bit and removing remnants here. Yeah. I can show you now here that I have trimmed that area. That is the superior turbinate here, there, which is now trimmed, okay, there. It's trimmed, and the medial aspect, I can almost enter here from between the middle and the superior turbinate. I can almost enter the posterior ethmoid, and I have more or less kept the mucosa and the olfactory cleft, and moreover, this is still stable. I was now trimming recto, my opening towards the posterior ethmoid, as you can see here. That is my posterior ethmoid, and that is pretty much open now. And if I want to open the sphenoid sinus transethmoidally, I have to go this way. And then if you draw a type of cake, like here, and you divide it in 4 pieces with a vertical line, imaginary line, with a horizontal line, you would take the inferior medial piece of that pizza, always remembering what I mentioned of the superior edge of the maxillary sinus, cucharilla recta. So in order to do that, you should enter with a straightforward straightforward curette, for example, and then go into that area and push inferiorly and medially, what is exactly what I'm doing right now, and then check whether you are in the sphenoid sinus. Again, the bone is very, very tough. It takes me a lot to push that now. I will now repeat that movement, going posteriorly and inferiorly there, but you will hear no sound because I think everything gets stuck with that sticky bone. Cucharilla recta. Sorry for that. I will put some cottonoid here and come back to you later. Respirador y luego una lentina. Sí, casi. So this side is almost done. The other side we had the, sorry, I'm going to clean this. We had the middle meatal antrostomy. I'm going to change my, no, I'm not going to change it. I'm going to do the, polypectomy again and check whether the polyps that could be seen here are attached or not to the mucosa. No, it seems, as you can see here, that we have the same situation. These polyps are not attached to the olfactory mucosa here. So we can use now the microdebrider, always taking care to have the opening of the microdebrider moving away from that mucosa. That is a very important moment here if you want to preserve the olfactory mucosa. And as you can see, I have succeeded in removing the polyps from the medial aspect of the superior turbinate up there, and also from the medial wall or aspect of the... Okay, now you can see, I have cleaned that. You see the choanal arch down there. Minor polyposis still here to go, but that's it. And a little bit of mucosal edema here at the superior turbinate. That's it. Okay, and now this was done. Now we can proceed here to open the bulla, if I haven't done it already. Yes, I did already. Here you can see I removed that part already. I gave that a small bite here. And now, look, I'm pushing hardly, but it's very, very tough. Okay, this is already the ground lamella. I'm opening now the superior third of the ground lamella, and you see the thickness of that bone up here. Irriga. Ahora. Okay. Aquí, sí, pues. Aquí, sí, menos, poco menos, sí. Okay, let's remove that superior aspect now. Irriga. Okay, now here we are, Irriga. Probably here, area of the skull base. So I need to stay a little bit lower, although I'm with a 0-degree lens. Okay, that looks good. That looks better now. See, there's a minor bleeding, but I still need to clean up the frontal up here and expose the frontal sinus opening. That's going to be tough because the bone was even harder on this side than on the left. Let's give it a try. Cucharilla curva 90. I will change the endoscope now back to the 45 degree in order to have a better overview of the frontal recess. Whenever you have a 45-degree lens, be aware that if you have to buy one, that the cold light source is coming out laterally towards yourself, because that will leave your working space as compared to those endoscopes where the cold light source comes out inferiorly. So here we are. This is still remnant of the frontal recess. I need to clean up. And the best thing to do if there are polyps, edema, which do not allow you, like in an anatomic dissection, to really dissect that stepwise, is to come from behind and anteriorly. And that is what I'm doing now. I'm putting myself behind bony rims and work myself slowly anteriorly. I can't do that fast because, again, the bone here is very, very tough. Okay, here we are. Get this out. Suction.
So Manuel, talking about the angled endoscopes, looks like you perform almost most of your surgery with the 45-degree endoscope.
Absolutely, yes. There. Here we go. You see there is still a slight septal deviation up here. Can you see that? And that pushes the middle turbinate a little bit more laterally as compared to the other side. Ahora. No, la pinza curva. You see that hanging polypoid tissue here. There we are. Now I've tried to see where is my frontal, and you can already identify the entrance. You see the mucosa of the posterior wall there going up, and then the very, very tiny entrance there where I'm entering right now. That's the tiny entrance to the frontal up there. And that's going to be a tough work like on the other side, because the bone here is very, very hard. Okay. Cucharia curva. The problem is that that entrance or opening right now is far too small to allow the use of the Hosselman forceps. So I'm going inside, and now that I'm in, I have to go out with the endoscope, and like with a house curette in middle ears, here, rotate slightly in order to trim that anterior rim a little bit. That has to be performed very, very careful, not to run into the orbit. Let me check now. But on the other side, I was happy that you were looking at the Paolo's angiofibroma, because it really took me a lot of work to expose that area and to open it. Hosselman. I'm going to try with the Hosselman. The advantage of the Hosselman is that there is a very nice tip, as you can see here. This is a very nice tip of the Hosselman forceps, as you can see now here, that allows you to a little bit punching into the area of the frontal. Let me check if I'm able to do that right now. And then the opening of that instrument really grasps the anterior bony rim. This is now rather by palpation than by seeing, also because of the bleeding. But now you have to believe me that I am in. Well, in the anterior area. Now, you see that I have removed pieces of small bone, and that is something the scrub nerve loves because this instrument is really difficult to clean. Again, we have to check that. Go superiorly again. And now what we can see is that I can almost enter now with the suction. Can you see that there? I am almost in. But that opening is very, very tiny, as it was on the other side. And, well, it will take a little bit of time. This is probably part of the skull base here. Again, yes, that is skull base. That's skull base. That's probably here. The suction, yes, irrigate. That's the supraorbital recess. That means that the anterior ethmoidal artery is somewhere here. So that is at least a little bit of anatomy I can show you. Vale? Huh? And then I have to work myself upwards.
Manuel, there is a question from
Yes.
Dr. Syed Hassan. It's about the intraoperative hemostasis and achieving optimum field during surgery. So what measures do you take to achieve that, to optimize your surgical field?
Well, that's a very good question. Well, first of all, as you have seen, I'm introducing constantly cottonoids soaked in topical anesthesia with and adrenaline or noradrenaline. That is important. And then, of course, having the blood pressure low. And then again, if I can show you from here, the patient has his thorax elevated as compared to the rest of the feet, and that reduces the orthostatic blood pressure again a little bit. And then if it's bleeding, you need patience. Put in cottonoids and wait, go to the other side, and work yourself from one side to the other. This side is going to be much more tricky than the other one because I can barely enter with my Hosemann forceps. So it's really removing bits by bits of that anterior rim. As you can see here now, I can almost enter with my suction here, almost. But I'm still not in. Una cucharilla curva.
Did this patient, Manuel, had any preoperative steroids or antibiotics? That's another question from Dr.
Yes,
Hassan.
he had steroids. And in fact, he had polyposis grade 3 that we succeeded to reduce to grade 1, 2. That's what we are seeing right now.
Thank you.
We do not prescribe steroids preoperatively routinely. And the reason is that we use a lot of material for our basic research. And if you have used steroids, then you cannot use the polyps for research.
Okay, there is also an interesting question. How do you differentiate between supraorbital recess and frontal sinus if the navigation is not available? So what is your view on that?
Well, first of all, you need to check the CAT scan. I think that's the best way to check all the cells. And not only in a coronal view, which is our surgical pathway, showing our surgical pathway, but also in, and particularly in revision cases, in a sagittal slice. That will show you how the cells are related to the frontal. I'm trying to see whether I can now enlarge a little bit. Yes, I could. Now the outflow tract posteriorly has been enlarged, as you can see. And it's still a little bit of bleeding here, but well, now it has been enlarged. So I have an outflow tract posteriorly, but I still need to struggle anteriorly because that bone is really stone. Okay, now you see the outflow tract here is now open. See that? Posteriorly, the posterior wall. Now I have to try to get rid of this anterior rim there. Can you see that? I will try whether I can outbreak parts of that bone with a curette, but I'm not sure because that bone is really tough. You see, I'm almost in. No, in this particular case, my impression is that that is mucosa from the posterior wall of the outflow tract, but I'm unable to really penetrate into the frontal here. I'm trying to use that as a house curette. You see there was a small bubble. See that bubble? Can you see that bubble now? Bubbles
Yes,
are our
yeah,
friends.
yeah, it's very
And
clear.
they indicate that we are pretty close to a cell, and in that case, the frontal recess. So I was very happy to see that bubble right now. Otra vez la de Joseman. Oh my God.
I think it will be interesting to know whether in this area there was a hyperostosis on CT scan itself. Was there any indication?
Yes, there was a minor occupation on both sides of the frontal. So in that particular case, I would say in almost all cases, at least I would like to see the opening of the frontal. You don't need to manipulate it like I'm doing right now. If you see it, if there is a good opening which guarantees aeration and drainage, you don't need to touch anything in that area. But that is not the case here, and therefore I'm struggling to enlarge that nasofrontal beak anteriorly. You see, I have already succeeded. My suction is almost in, okay? But I still need to remove more. And I would like to see a little bit of more bubbles, as I could expose on the other side. Coming now below my instrument. I'm in, wait a minute. I'm using the curette again as if I was using a house curette. But that bone is, wow, it's amazing. So I'm not sure whether I should now proceed in doing a drilling or a larger opening because of the minimal occupation of that frontal, you see. Now you can see it a little bit better there, medially. I'm in now. Now I'm in. I can show you again. That is now the opening. Can you see it? Up here, there. And that needs to be trimmed a little bit, unfortunately. But that takes its time because of that particular situation of the bone. Now I'm in with a Hosemann forceps again, biting away anteriorly. I want to keep the mucosa or mucoperiosteum of the posterior outflow intact. That is the bone I have been removing. And now the instrument needs to be cleaned again. And I can show you whether I have enlarged that opening a little bit more. Can you see it now? It looks better, but it's still not enough. And that's going to be very tricky because the opening is right 2.5 millimeters, the size of the tip of this von Eycken suction. And that is not enough to guarantee a good aeration and drainage. So I will still need to work further. And that is a little bit tricky because you're working around the corner. That's really tricky there. Sorry for that. I would have liked to show you an easier case, but that's not bad that you see that we may struggle a little bit depending on the anatomical situation and the situation and condition of the bone.
It's
Again, I follow the
hugely
instrument.
educational. Hello, Manuel.
Yes.
I think it's hugely educational to have a case like this where how you sort of deal with the intraoperative difficulties. So there is an audience question in relation to this about use of navigation. Are you using any navigation at this stage? And
No. We have the
okay, so
navigation
what is your policy
somewhere
about
here.
navigation?
I have to say that I use it very, very rarely, if ever. The reason is that, for example, there would be an indication if this was a revision surgery of the frontal recess and the frontal proper. Then I would say good. In order to be on the safe side, you can use it. But in a primary case such as this one, I can still follow my landmarks. So if I can follow my landmarks, I don't see an indication to use it. The opening is now a little bit larger, as you can see, because I can really go in and out with a suction here, but it's still too small for a spontaneous healing. However, coming back to the navigational system, if you feel confident with that, it's not that I'm saying no to the navigation. It's just saying that, well, we use it very rarely. But if you have it and you use it, do it. It's not a problem using it. On the contrary, it trains. I think the skill curve, the learning curve goes up a little bit more steeper if you're using that. But the trick of using the navigational system is please use it to confirm what you believe it is. It's not the other way around. So if you do not know where you are, you can use it as an orientation. But then remember, it is not being created for millimetric decision making. So it's just an orientation. That's how we use it, when we use it.
Thank you.
Yeah, okay, as you've seen, we have come from scratch to have that opening up there, which is not that bad, but it's not enough. A very good study was performed by Werner Hosemann, whose instrument, by the way, I'm using here, showing that you really need at least 4 millimeters, 5 millimeters to opening to make sure that the frontal will stay open. And as you can see, I'm only biting with that instrument anteriorly. I'm not pushing posteriorly, not biting posteriorly. Otherwise, I will remove the whole mucosa in that area, or mucoperiosteum. Well, this is a very, very tricky situation now. Okay. Another trick when working in the frontal is put in the smallest suction there. Tenemos un punch curvo. Punch curvo. No, curvo. Pues deme otra vez el. Is to make an irrigation of the frontal sinus proper. So while the water is coming out, it flushes away the blood. Now, in the open back, he's improving, but again, it's not enough. I'm very sorry for this frontal so far. And also in this particular case, the frontal recess is very steep, as you can see. And that makes the thing a little bit more difficult. There we are. That's the opening. You see there's mucosa there. But the bone, wow, the bone is amazing. I see now that there is a minor cell behind. Can you see that? Just identify that cell. I'm pushing now with the suction. Can you see that? That cell here. Okay, now that I have identified that cell and broken in the wall, can you see that now? I can remove it with a curved curette, hopefully. Cucharilla curva. And then I will have a larger opening. But that cell was firmly attached to the surroundings, and I could not identify it until right now. This will leave us with a much larger frontal opening, as you will see immediately. Provided I'm able to get it out. But had I not removed the anterior beak, I would have not been possible to trim that area. Let me check now. Is this an opening? Yes, that is one. Okay, yeah, that's it. Oh, that was a huge cell. Can you see that? That cell was growing into the frontal there. Cucharilla curva. No, perdón, las pinzas curvas. Se pueden ser, bueno, vale. I think this will leave us with a very nice and large and generous opening, as I will show you in a minute. Estas pinzas no cogen bien, lo siento, pero estoy estirando y no escogen. Respirador.
Manuel, can you show us more detail about this cell, where the cell was, what was the location, please?
Yeah, so there was a cell starting to grow here and going inwards there. And now I have removed them. Deme la cucharilla, no, la pinza de Kumbolger grande. Now I can see that I have really opened the frontal recess, but I was not aware that the cell was coming from so far inferiorly. There it is, and there is the bone coming from there. Déjamelo aquí, si no tardamos tanto en comunicar. Now you will see that once I have removed this, I will have a larger opening. La de Hoserman.
Manuel, there's a question in the audience that what would you call this cell as? Was it in relation to the frontal recess?
I didn't get the question.
How will you describe this cell in relation to frontal recess? What cell will this be? Whether it's a anterior or posterior, or is a Kuhn or supraorbital cell? That's what the question is.
It's a more posterior cell. Wait a minute, we're going to get rid of the blood first, then show you. Still a little bit of the mucosa I want to preserve on the posterior wall and then remove the more anterior beak. See that beak here? There's a small beak. Here we go. There, that beak. Then you see the mucosa. So the opening is here. That is already the opening of the frontal. Hosemann. Very tricky situation indeed. But you see the bubbles? That is a good sign that I'm very close now to the frontal. And now I'm in. That is now the frontal here. I'm in the frontal. This is the frontal. Can you see that? With that mucosa here. And now I can measure, if you like, can still remove that polypoid mucosa up there. I can leave the mucosa at the posterior wall and remove the anterior wall of the anterior wall and inside the frontal. Kuhn-Bolger pequeñito. It's so steep that with my Kuhn-Bolger forceps, I can barely reach that area, as you can see. I'm already at the top here. I cannot go further inside because that is so steep. It's important. It's very interesting. Okay, vamos a irrigar. But well, at least that is now widely open, as you can see. So I have an opening that goes from here medially to laterally there, okay? And now we have a larger opening. Can you see that? I think that is fine now. I don't need to trim that further. And the only thing I need to do is the opening here posteriorly of the posterior ethmoid, but just for the sport of it, because there were no polyps inside there. 5 minutos. Escucha, dime la recta. No, y el aspirador recto también. So that was the frontal, very tricky one. We could solve, and now let me see. That is the ground lamella here. We have already opened down there the posterior ethmoid, as you can see, down there. Vamos al microabridador. I will now use the microdebrider to trim that a little bit further. Here we go. You want to see? Posterior ethmoid, as you can see here, that is clean, so I don't need further actions to be taken here. Just to trim the little bit the rim. Okay. Well, I think that was it. Are there further questions from the audience? Let's go.
Thank you. That was quite an interesting case. Difficult with the access and bleeding.
diprogenta. What I like to do is, after having manipulated the mucoperiosteum of the frontal, as we have done here, is to put in some ointment that contains some steroids, topical steroids, in order to reduce the, there's some loose, bony piece, pinzas curvas, y me llena la diprogenta. And no, Kumbolger no, las pinzas curvas. You will see what I mean, and that ointment melts with a body heat, comes down, and keeps that area con esta. You will see what I mean. Should there be need to keep that ointment longer period inside of the frontal, you can put some tyromycin at the entrance. That is what I mean here. So this is a creamy ointment that will melt slowly and come down and keep that opening aerated. Same here. That's it, you don't need more. Now, very important, you now need to pack this thing, and you need to be aware of not out-fracturing the middle terminate when packing, because that's the next risk. So make sure there is no bone remnant somewhere here. Check all remnant bleeding. That's it. Okay, taponamiento. So if that is the case, in order to prevent, you either put a short packing here into the middle meatus, that is an option, or you put a packing just in the inferior meatus there, catching the bleeding, potential bleeding, and then I like to remove this after 24 hours. These are finger cut packings. They're very soft and easy to be removed. So thank you very much, Ashok, also for taking on your shoulders that huge organization that is needed to get such an event well organized. I'd like also to thank the staff here in the operating theater for their nice job.
So thank you, Manuel. That was wonderful. You've always been a great supporter of LION-ESS, and your surgeries have always been very educational. So thank you to Isam as well, your immediate colleague in the department, and who is going to join to us shortly with his next case, which is meningoencephalocele with the CSF leak, I hear. So again, a very interesting case, so looking forward to it. So stay tuned, and thank you to your theater staff. So Manuel, before you go, we'd like to know your post-op management.
Pardon?
We'd like to know what is your post-op management for this patient.
The post-op management. Okay.
Yes,
I would remove the packing tomorrow or after 2 days, depending on the type of surgery. Of course, here there was no septoplasty included, so no need to take care of the septum. So you remove that, and then you see the patient a week later. Personally, I do not start to use any lavage and rinsing with saline until a week later. Also with the topical steroids. So after a week, 10 days, I see the patient again. I remove whatever fibrine clots or old blood is in the maxillary sinus, and then it's when they start rinsing the nose with saline and applying topical steroids. And then I see the patients, depending on what I have done, I see the patients every 10, every 14 days, more or less. At the beginning, that would be 2, 3, 4 times, depending on the situation, and then every 3, 4 months. Important to understand is that it is not just prescribing topical steroids to the patients. You need to explain them carefully how to use them. And most patients use the topical sprays just like this, chuff, 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 and then these spray and the content goes into the nasopharynx. You need to explain to them that they need to lay down somewhere in the bed and then have their head hanging backwards so that the spray really works upwards into the olfactory cleft and to the area of the frontal. Another alternative is using the rinsing with saline and then using a full bottle of topical steroids dissolved in that saline solution. That is, of course, a little bit more expensive. And otherwise, it is very important that the people keep on rinsing the nasal fossa on both sides. And another trick I tell them when patients come to me is, I ask them, how do you rinse that? And many of them tell me, oh, I use a 10 cc or 20 cc syringe. That is, of course, not enough. You need at least a 50 milliliter syringe. And if they do not have any other devices that are very good for rinsing, and I use to tell them that they need to put force behind the syringe, so that I want a strong lavage to get rid of the smaller crusts. Another indication which is very important in the follow-up is you may remove those crusts who are loose somewhere in the millimeters or elsewhere. Those crusts that are strongly attached to the mucosal surface, keep them there, because otherwise, if you try to remove them, you will withdraw also newly ingrown mucosa, and that perpetuates the crust formation. So wait until the crust gets detached from the surface, then you can remove it.
Thank you. How often would you see this patient post-operatively? How long? What's your protocol, local protocol of following up these patients?
Yeah, well, that strongly depends. We once made a study to check how long the tissue took to scar and heal endoscopically. And we found out that revision surgery cases took as much as double the time as patients operated by a primary surgery. So you need to take care of that too and be aware. And then the follow-up strongly depends on the basic condition. This particular patient has no asthma, has no aspirin intolerance. So basically, if the sinuses remain aerated after 6 months, 7 months, you see him, everything is good. He has no more complaints. Olfaction has resolved and come back. Then you can see these patients every second, every third year, if needed. The other conditions where you have patients with asthma, with aspirin intolerance, with Churg-Strauss syndrome, for example, these patients you need to see more frequently. On the long term, if you have a patient that after having undergone a good surgery has a type 1 polyposis on both sides, and after a year, he or she still has a type 1 polyposis, you can see them every other year. But one of the indications I give my patients is the key symptom in order to know whether the inflammation is coming back used to be olfaction. So if your olfaction came back after surgery and treatment, and one of a sudden it starts to get worse, that's a good indicator that the inflammation is coming back. even if you do not see polyps yet. So that is the advice I give my patients. They take care of themselves. Very important to instruct them. It's not us. The second point is explain very well, particularly in the patients with the worst conditions and the massive polyposis with that sticky mucus and glue, is that they have to understand that they have a systemic disease and that you are just treating these areas in order to improve aeration and ventilation. But on the long term, even the best of treatments will make them come back with a major or minor polyposis, and that was not your fault, but that is a systemic problem. If they understand that, they are not getting angry at your surgeon or you or the surgeon saying, hey, he did not well do a good surgery upon me because I have my polyps grown back. That is not a problem of the surgery, it's a problem of the systemic disease. And if you explain that well to the patients, they will come back to you.
Thank you, Manuel. So that was a wonderful case. And before we get ready for the next case with Isam, we'll have a break. So over to you, Wilco.
No, pondrán.
Hello, Wilco. Professor Grollman, are you there? So Manuel, will you be joining us back in the same theater again?
Pardon?
Will you be joining us back again in the same theaters?
Yeah, we're waking up the patient. The other one got intrathecally applied fluorescein already. So it's going to be a nice case as well.
Yeah. Yeah.
Operated
if you have
by
images, we can.
Professor
Thank you. If you have any images, we can. We got time to talk about the next patient and their presentation.
Great. You mean later or now?
No, we can talk now if you have the information.
We can talk now. Is that you want to present the patient? Wait, we need to switch the micros. No, we don't. We have several micros here.
Thank you.